Good afternoon. I'll share my views on whether to operate on an asymptomatic patient with moderate sized VSD and LV Z-score of +2. Indications for closure of VSD depends on the age of the patient, the size, number and location of the defects, hemodynamic parameters like the shunt magnitude, pulmonary vascular resistance, whether a complication like endocarditis has developed, or anatomical factors like collapse or RVT obstruction. A moderate VSD is less than 50% of the size of the aortic orifice. PA pressure is less than 50% of the systemic pressure. Shunt is moderate and LV volume overload is present. Indications for closure have appeared in guidelines. American Heart Association guidelines says it's class 1 when the QPQS is more than 2 or when there is clinical evidence of LV volume overload. European Society also gives similar class 1 guideline if there is LV volume overload regardless of the symptoms. So our patient population which we are now discussing is falling in this category. Indian National Consensus a couple of years back suggested that a moderate sized VSD, if asymptomatic, should be operated by school age. If symptomatic, by 1 to 2 years of age. They all have cardiomegaly. This cardiomegaly is because of left ventricular volume overload, as can be seen on M model. And the pressure volume loop of the volume overloaded left ventricle shows an increase in the preload, which has a deleterious effect on the myocardium. These scores were developed to determine options for management when the structures, cardiac structures, the size of them increases with growth. How much the measurement deviates from the population mean? This is the mean. How much deviates from the population mean? 1 or 2 standard deviation. That was the Z-score. It helps to compare serial measurements over time. But there are limitations. Not all measurements are normally distributed. Depending on the different models of population or different models where the nomogram has been obtained, and also depending on the methods used, it can give different Z-scores for the same measurement in the same patient. For example, RPA measurement in the Detroit and the Wessex population, one was in this. So it can give different measurements. And there can be amplification of errors. With a mitral valve plotted against the Z-score and the mitral valve size, depending on the methods or the models, there can be variation in the extremes of the valve size. Also in adults, it is seen when the Detroit or the Wessex models were used, there was a wide variation in the extremes of the aortic size. The Z-score for Indian population was also developed recently, and it is seen that LV dimensions are less. In other words, we need our own Z-scores. When we compare the surgical and medical follow-up patients of ASD, medical follow-up because they require medical management because of not the dilated LV or because of small shunts. The LV Z-score was higher in surgical group, but still there was considerable overlap. Some of the patients who had surgery had low Z-score, whereas some of the patients who had medical management also had high Z-score. Spontaneous closure also to be discussed before deciding on surgery in VSD. The maximum rate of closure is before 3 years of age, but even up to 10 years of age, a large majority do close, especially if they are small, and higher chance for a muscular defect to close. In adolescents also, there is a diminution in size in up to 1/5 of the ASDs. Outlet ventricular septal defects, however, very small chance to close, and malalignment defects also usually do not close. Inlet defects never close. Spontaneous closure in the newborn on follow-up is higher chance when the VSD size is less than 4 mm diagnosis or if it is a muscular. Also, spontaneous closure is possible if there is no pH, defect size is small, and the diagnosis initially is made at less than 6 years of age. In other words, less than 6 years of age, small defect, and no pH, chances are closure are very high. These are the moderate defects. And LV size is small in such patients. What happens to unoperated VSD when the ubiquitous or the shunt is of low magnitude? It was seen that if they have poor exercise capacity, the red line indicates the oxygen uptake on exercise compared to a normal controls. There is a reduction in the oxygen uptake. So, exercise capacity reduces. Same authors found that RV function is also abnormal in these patients, and this abnormality was pronounced during exercise. Here also KPKS was not very high. The cardiac index on MRI was lower in these patients with a shunt of 1.2 only, and the pulmonary retrograde flow was larger. In other words, antegrade flow became reduced because of a fixed pulmonary vascular resistance, even in patients with a small shunt. They also have abnormalities in the parenchymal function. Restrictive airway disease develops in them, and some of them even have a reduced ejection fraction, higher size of the LV and LA. This is because diastolic dysfunction develops, which gives rise to a continuous rather than a systolic shunt through the same small defect. So, an asymptomatic moderate VSD with 2+LV Z-score, when we consider surgery, this score is important, but it's not the only criteria. If muscular VSD is seen, especially if the child is, say, less than 6 years of age, one can follow them up. If the VSD initially is 4 mm at the diagnosis, and especially if it is a perimembranous or outlet defect, they are unlikely to close. So there is a lower threshold to close in them. Morbidity, mortality in today's surgical hands is very low. So these patients with 2+LV Z-score, even if asymptomatic, are candidates for surgical closing. Thank you.